I will introduce our first speaker. He's Mr. Ken Janda. He is the principal of Wild Blue Health Solutions LLC, which is a consultancy bringing people and solutions to the challenges in our healthcare landscape. So prior to starting Wild Blue Health Solutions, Mr. Janda was the president and chief executive officer of Community Health Choice for 11 years. And for those of you who don't know, Community Health Choice is a Texas-based nonprofit managed care organization that provides innovative health insurance plans to low-income families. So Mr. Janda is also an adjunct professor in the Jones School of Business at Rice University and serves on the Dean's Advisory Committee to the School of Social Science at Rice. Mr. Janda is a graduate of Rice University and also the University of Houston Law Center. So we'll welcome Mr. Janda to the stage.
So I'm coming off a little bit of a summer cold, so if I just sort of start coughing wildly. Plenty of doctors in the house though, right? Take care. So I have to correct the pronunciation of my name. The reason why it's Wild Blue Health Solutions is because it's Wild Blue Janda. So Janda is actually pronounced Janda. It's the Czech pronunciation. Going back to when my son was in high school and trying to explain to people why we were hanging on to the Czech pronunciation, so Wild Blue Janda, but also implying thinking of things beyond what we normally would think are possible as it relates to health and healthcare. And so happy to be here. I will also say Doctors for Change take people who are not doctors, but I'll also point out that I have a Juris Doctorate in law, so do I count as a doctor? Close enough, right? Close enough. So I only have 10 minutes, which, for those of you who heard me speak before, know that that's going to be a challenge. So I'm going to go really fast. So we're going to go right into the lightning round of what's going on. Okay, so the first thing you have to know is what this current system is right now. So you've got about 330 million people in the United States, of which about 15 or about 12% of them or so are uninsured, as Mark said earlier, more in Texas than other states. But most of them do have health insurance. And of course that's important because having a health insurance card is nothing magical, except it does give you access to care and keeps you from catastrophic financial ruin. So it's good that most people in the United States have health insurance, but not everybody does. Most of the people that do have health insurance have private insurance, either through their employer or direct purchase. And then quite a number of people have government plans, either Medicare, Medicaid, or military health, right? So you got that's like, what? No wonder why it's so confusing, because actually if you look at employer-based insurance, there's actually different rules for small employers versus large employers, and then many large employers are actually self-funded. They don't buy insurance at all, so it's quite confusing. What you see over here is the change for the last 5 years. So something pretty dramatic happened between 2013 and 2017 to reduce the number of people who are uninsured. Any of you ever heard of the Affordable Care Act? Yes. Was really an amazing, certainly in my 38 years in the health insurance business, the biggest change that's ever happened in that period of time. You'll notice a lot more people with insurance. There was growth in private insurance, not very much growth in employer-based insurance. Most of the growth was people buying direct individual coverage, and that's the people in the health insurance marketplace that could go and buy their gold or silver or bronze plan, and they got federal subsidies for that. So big growth in that area. Big growth in government plans. One, in Medicare, because there's more old people every year in the United States. We are aging. And secondly, big increase in Medicaid, except not so much in Texas, because Texas did not do the Medicaid expansion, and not much change in people in the VA system or the TRICARE system for military. So this is kind of what it looks like. If you think about who has what kind of insurance, think about it by babies down here, old people over here, very poor people, rich people, okay? So basically, young, children and pregnant women have Medicaid, a few disabled people have Medicaid, old people have Medicare, except old people who are in nursing homes they're dually eligible for Medicaid and Medicare, many of them, if they're low income. So you have a lot of old people who have both Medicare and Medicaid. You think both of those are confusing programs, but here you get two cards, right? It's really, really challenging. Here's the people
below 400% of the federal poverty level. 400% of the federal poverty level is basically if you make less than $50,000 a year and you don't have employer-sponsored insurance, you can get a subsidy under the Affordable Care Act. And people over $50,000 basically are working for employers and they have health insurance. Most of the uninsured people then are people very low income adults, and those people are, in many states, are eligible for Medicaid, but not in Texas because Texas decided not to expand it. And then a lot of these people in the 20, 30, 40,000 low-wage people, sort of the working poor, we call those folks, a lot of them do not take either the subsidies of the Affordable Care Act or they can't afford their employer-sponsored insurance. So that's why there's a lot of uninsured people out there. And then you add on top of that people who are actually eligible for Medicaid that don't sign up because they're scared that they're going to get deported if they do that because somebody in their family may not have the appropriate papers, and lots of other reasons why people don't sign up. But that's kind of, it's a mess, right? You know, so anyway, oh, I already did this slide. So low-income people that are not signed up for Medicaid, low-income people who are not eligible at all because of their immigration status, undocumented folks, low-income adults that would be eligible in other states, part-time workers, people that work for small employers that don't offer coverage, and then people that just, there are a few willfully uninsured people, but frankly not that many out there. So here, Medicare for all, right? Right? You like this one or you like this one better, right? So that, I think that's what people think Medicare for all means. But of course, that's maybe not quite perfect. Because if you think about what Medicare is right now, Medicare itself is kind of complicated, right? Because in Medicare you have Part A, which is for the hospital coverage, Part B for like physician services and other kinds of things, Part D for prescription drug, which was only added in 2006, something like that? Yes. Medigap, a lot of people on Medicare buy a supplemental policy on top of their Medicare coverage to cover deductibles and services that aren't otherwise covered. And then of course you have this other thing called Part C, which is Medicare Advantage plans. And you now have a situation where over a third of all the people on Medicare are actually not on Medicare. They have a Medicare Advantage plan, which is an HMO or a PPO, a private insurance company, that takes the place of all this other stuff. For those of you who want to get into the financing of this, I won't tonight, but it's really complicated how it's financed. And people think, I paid for my Medicare, I deserve my Medicare. Well, the only part that you pay in your payroll deduction is actually for Part A. Part B, C, D are all general revenue. So I always get annoyed with people who think, well, these poor people don't deserve health care, but I do deserve my Medicare. Well, it's all government funding. So what is Medicare for all? What are the different proposals out there? So you have Medicare for all, which is kind of the Bernie Sanders version of it, which we'll talk about in just a minute. But then there's Beto and other people are saying, well, we'll have a national health insurance plan, kind of like Medicare for all, but if you have an employer insurance, you can keep your employer insurance. And then you have people like Joe Biden who are basically saying, let's fix the Affordable Care Act and let's add a public option. Let's add sort of a Medicare option for people on top of the choices that they have right now. There's other people that want to just do something simpler, which is just like people over age 50 can buy into Medicare. There's other people that have proposals that say, well, actually what you should do is buy into Medicaid, because Medicaid actually has no deductibles, no premiums, no co-insurance, unlike Medicare. And so there's all those kind of options. Then last week, Kamala Harris, Senator Harris from California came out with, well, we're going to have Medicare for all, but we'll leave the Medicare Advantage plans out there so you can still have your Medicare Advantage plan so that the insurance companies could stay. And then day before yesterday, I saw Pete Buttigieg came out with a Medicare for all who want it. I'm not quite sure what that means, but so if anybody, and we'll have some more discussion about this, but I have to tell you, I'm not quite sure I know what Medicare for all means. If you're coming here to find out, I'm not sure. Maybe by the end of the evening, after 3 other speakers, you'll know. But I think what Bernie Sanders is talking about is a single federal program that has comprehensive benefits. more comprehensive. He would get rid of A, B, C, D, and put it all together in one comprehensive benefit without the separate deductibles and co-insurance and all that's in the current program. It would all be financed with tax dollars, no premiums, no very limited cost sharing in terms of co-payments at the time of services. Everything else is gone, right? That chart that I showed, I mean, everything else is gone, including Medicaid, CHIP, private insurance. Those of us who spent their entire career working for health insurance companies, I guess we'd be gone too. You'd also add dental, vision, and other services that are not currently covered under Medicare at all. But the payments, I had to put this one in there so all of you doctors out there. His proposal is to pay all the doctors and hospitals at the current Medicare rates, which are better than what you get for Medicaid, but not as good as you usually get in commercial insurance. And so there's been some economic analysis of that that says that may not be good for doctors and hospitals to get everybody paid at the Medicare rates. And so there's a bunch of economists that have looked at this and sort of said, okay, we think that the 10-year cost of this is $33 trillion. It would be very expensive to do this. There's some other estimates. The lowest one I could find was 25 trillion dollars to do this. We could do Medicare for all. I mean, there's no doubt that it could happen, but it would be expensive. And the way that it would be financed is, Senator Sanders says 7.5% tax on employers, 4% tax on employees, fees from financial institutions, more aggressive estate tax, personal income tax higher for rich people, and a new tax on extreme wealth. I'm not quite sure I know what extreme wealth is, but and repealing corporate accounting gimmicks. So he thinks he could pay for the system. But you also, it's not just paying for it, but it's all these other things that those of us who lived in the health insurance world for a long time think about. Is like, the administration of this is complicated, right? Even just to keep track of who's eligible, who's not eligible, where they live, all that kind of stuff would be challenging. And frankly, the federal government does not do a lot of the administration right now. Under Medicare, as I said before, a third of the people are already in private insurance programs called Medicare Advantage that are sold by Humana and those kind of guys. And the other 70% or 65% of the people, there are fiscal intermediaries in every state or in regional that do a lot of the work. So it's not clear how the administration would work, eligibility, exactly what's covered, what's not covered is not clear. If there's any role for what goes on in the current system, the provider rules, how much is going to be paid. And frankly, in Medicare, traditional Medicare, there's not a lot of cost control mechanism in terms of reviewing of utilization or what services actually work, and not nearly as much as in the private insured basis. So there's a lot of details to sort of think about with all that. So here's my list of big questions to tee up for the other speakers is, okay, how much would this really cost? I'm sorry, I'm a financial guy, I always think about cost first. You would have about 160 million people with private insurance that you'd say, right? I don't think we have a lot of people here on Medicare, right? Most people here have private insurance right now. Sorry, you have to change your insurance again. You'd be taking and asking employers and employees to convert what they're paying right now to new federal taxes. You'd be asking for, since the Medicaid program would be going away, you need money from the states that are paying for their Medicaid program to kick in. Again, as I mentioned before, how much doctors and hospitals really get paid, and could they survive on that? Do they have the infrastructure to do this, to bring in 250 million more people into the existing Medicare system? That's a big lift. And you'd eliminate 500,000 people that work for health insurance companies right now. Right. Not me anymore. I have my own small little consulting firm, but many of my friends. Really the other big problem is you cannot believe how powerful the health insurance industry lobby is. Pharma doesn't want this. The hospital associations don't want this. The medical associations, at least the ones that lobby in Washington, I'm not saying you guys, but AMA doesn't want this. AHIP, which is the health insurance plan, doesn't want it. I'm, even if we all decided it was a great idea, I am somewhat dubious. And so you start seeing these other things going on. But Astros were ahead 6-2 at the top of the ninth a few minutes ago. Don't worry about this. I'm a huge baseball fan. I always, any kind of healthcare proposal, I say we need to think about how does it do on running the 4 bases, right? This is the evaluation technique. This is the Ken rubric for deciding if it's a good idea or not. So the first thing is, what does it do for building personal accountability? Because I say that we live in the United States and everybody should make their own decisions about their health and they're accountable for their own health and all the rest. Does this help or hurt that to get to first base? Second base, does it cover everyone? I think most of these proposals do pretty good on getting to first, second base, but I'm not sure if this gets us to first base to start with. I think it does a pretty good job of setting from second base to third base, which is simplifying the administration, right? At least there'd be all the same rules. We don't know if we like those rules, but at least it'd be the same for everybody. And then probably the biggest one, and of course you don't like to leave runners stranded on third base. You want people to get home, and that's about slowing healthcare costs, because the United States getting close to 18, 19% of GDP right now, almost double what any other country spends on healthcare. Is this the best way to control costs long term? So we will see if how far this goes. But what's encouraging to me is we have some people who are putting something kind of bold and big out there that we can react to. I'm happy to continue the discussion, but I'm going to turn it over to one of the other speakers who's going to talk a little bit more about the pros and cons of this, and then I'll be back for the panel later.